Dr. Charmi, I think we can.
Sir,
Yeah.
yeah,
Uh,
I'll start with countdown, sir. 2 minutes.
sure. Let me know so that I'll go live.
Yes, sir.
Just
So
one
we
second.
are ready now. We can start in 3, 2, 1. Please start, sir.
So good evening, one and all. Good evening, fellow doctors, all across uh, our wonderful country, right from the north to the south to the east and the west. So good evening, India. Uh, Today we are in for an academic feast that is to follow. As you all know, the ESC guidelines have just been out on numerous topics and a lot of wonderful updates shared at the ESC. We also have today one of the brightest minds to enlighten us in the field of cardiology. Nevertheless, very quickly coming to our scenario. As we all know, India has the second highest rate of CV death in the world, with key modifiable factors being a high systolic blood pressure, uh, dietary risks, as well as a high LDL-C cholesterol. The very recent ICMR INDIBE 17 study, which was published in The Lancet, threw light not just on the huge diabetic burden that's there in the country, with a projected value of 101 million, but also an important point being pre-diabetes, 136 million being the projected numbers across the nation. Uh, Also, not to be ignored was actually hypertension, which was 3 times more than that of the diabetic population, with 315 million projected hypertensives. And again, being hypercholesterolemia, especially with a focus on high HDL cholesterol, being projected in at least 185 million Indians. Also, does the scenario maybe pen a little different for Indians compared to our Caucasian brothers? Yes. So, as you all know, we Indians tend to have a much more visceral obesity. We tend to follow the thin fat phenotype, wherein probably we look thin outside phenotypically, but have a lot of visceral adipose tissue. We tend to have a lot of clustering of metabolic risk factors. Our dyslipidemia tends to be atherogenic, a typical atherogenic dyslipidemia with a high LDL, a reduced HDL, and an increased TGL. Also, we tend to develop vascular disease, documented vascular disease, at least a decade before our Caucasian brethren, which is why it becomes all the more enough reason to keep our thinking hats, our thinking caps on, and our antennas high when we practice. So, to discuss on the same, I have the honor of inviting one of the most astute uh, teachers in the field of cardiology and medicine, Dr. Andrew Coates, who's known wide across the world. I have the honor of introducing sir. Can we have the full screen? So we have, it's our honor to have Dr. Andrew J.S. Coates, who's the Professor of Cardiology and the Scientific Director of Heart Research Institute, NSW, Australia. He's also been the immediate past president of the HFA, the Heart Failure Association at the ESC. He's served as the director of Monash Warwick Alliance and is also the academic vice president of Monash and Warwick Universities and has higher doctorates from the Oxford as well as the Imperial College. In the past, he was appointed as Viscount Royston Professor of Cardiology at Imperial College in 1996, the Director of Cardiology and Associate Medical Director at Royal Brompton and Harfield NHS Trust, and Dean of Medicine at the University of Sydney. He holds fellowships in various international bodies, as you all can see, and as you all know. He's published more than 10 textbooks, more than 15 government reports, 2 Cochrane reviews, and ladies and gentlemen, over 500 peer-reviewed papers in peer-reviewed indexed journals. His research interests are in chronic heart failure, hypertension, and organizational behavior. Dr. Coates, it's an honor to have you, sir, with us. Over to you for the academic feast that lies ahead.
Thank you very much, Dr. Patsari. Let me share my screen. I'll just get there. Is that full screen yet?
No, sir, not yet.
No.
The slides are visible and they're full screen, sir.
Okay, thanks very much. So my great pleasure to present to you. So as mentioned, I was president of the Heart Failure Association ESC 2020 to 2022, and I'm now scientific director and CEO of the Heart Research in Sydney. And I'd like to present the highlights I picked up and the guidelines from the most recent ESC meeting. So first of all, there was a focused update of the 2021 ESC guidelines that I had the honor of serving on. And this focused update looked at new changes in the 2 years and new recommendations, particularly for chronic heart failure. A new format was more definitive recommendations for the group of heart failure with mildly reduced ejection fraction, those patients with heart failure and ejection fraction between 41 and 49%. And we now have, based on recent trials, strong evidence for the use of diuretics for fluid retention and dapagliflozin, empagliflozin, the SGLT2 inhibitors, with a class 1 recommendation for treatment of HFmrEF because of their efficacy in both HFrEF and HFpEF. There's also some gentle recommendation, a class 2B may be considered for the group of ACE, ARNI, and ARB, within which ARNI is preferred, mineralocortical receptor antagonists, and beta blockers, based on the fact that these were subgroup analyses of older trials. There was also an update on the management of patients with HFpEF, and here we had significant change because we now have for the first time a disease-modifying drug class that have the SGLT2 inhibitors, as exemplified by dapagliflozin, empagliflozin, given a class 1A recommendation. And of course, that's based on the results of the Emperor Preserved trial and the most recent DELIVER trial of dapagliflozin, both showing significant reduction of cardiovascular mortality and or heart failure hospitalization. There are also recommendations for diuretics and treatment for detecting the etiology and treating cardiovascular and non-cardiovascular mortality. What were new recommendations? We also saw for the prevention of heart failure in patients with type 2 diabetes, and recently evidence for prevention of heart failure in patients with chronic kidney disease. And what we have is for patients with type 2 diabetes and chronic kidney disease, the SGLT2 inhibitors, dapagliflozin, empagliflozin, recommended to reduce the risk of heart failure hospitalization or CV death with a powerful class 1A recommendation, as well as a class 1A recommendation now for the treatment of diabetic patients with CKD, chronic kidney disease, with the new non-steroidal mineralocorticoid receptor antagonist, finerenone. So now we have some major new ways we can modify and prevent heart failure, hospitalization, and cardiovascular death in CKD patients. Clearly, we're seeing a merging together of these cardiorenal metabolic syndromes. We're getting common drug classes that are working across all three diseases: type 2 diabetes, chronic kidney disease, and heart failure. There was also a new recommendation, and this is a very important, very clinically relevant one, of the management of pre-discharge and early post-discharge follow-up of patients hospitalized for acute heart failure. We'd known what was recommended for the treatment of chronic heart failure, but what was controversial is how quickly we should commence these agents, how rapidly we should attempt to get all four recommended drug classes on board, and whether we should start initiation and up-titration in hospital stage. So this trial, a very important trial, STRONG-HF, randomized patients in a pragmatic design to conventional management with outpatient initiation of new treatments and up-titration versus a special rapid up-titration of evidence-based treatments starting before discharge, but including frequent weekly and careful follow-up visits in the first 6 weeks following the admission, with an attempt to get all the recommended drug classes on board. This trial was started when there were 3 recommended drug classes, but based on recent evidence of the benefits of SGLT2 inhibitors admitted in hospital, the recommendations now include all 4 drug classes, the beta blockers, the ACE-ARNI group, the SGLT2 inhibitors, MRAs. That's given a class 1B recommendation, the B because there's a single trial, the STRONG-HF. But this is telling us that we need to get a much greater sense of urgency and speed in initiating and up-titrating evidence-based treatments for heart failure after an acute hospital admission. And this really tells us we need to move much more quickly and improve the the speed of ascertainment of protective therapies. There was also an update in the management of iron deficiency in patients with heart failure. We have a Class 1A recommendation, which is unchanged, of intravenous iron supplementation for patients with symptomatic HFrEF and HFmrEF, mildly reduced ejection fraction, and coincident iron deficiency to improve symptoms and improve quality of life. There was a Class 2A recommendation, so should be considered, of the use of IV supplementation with ferric carboxymaltose or ferric direzomaltose, these two formulations in symptomatic patients with HFrEF or heart failure with mildly reduced ejection fraction to reduce the risk of subsequent heart failure hospitalization. We also had the 2023 ESC guidelines for the management of cardiovascular disease in patients with diabetes. What we see here is that there's a central figure recommending the management of cardiovascular disease in patients with type 2 diabetes, incorporating the full clinical approach, and that is to evaluate patients with established cardiovascular disease and look to see if they have coincident type 2 diabetes, and evaluating patients with type 2 diabetes and evaluating to see if they have either CV disease or chronic kidney disease. When confirmed, they lead to particular recommendations for treatment down the bottom of that, and they are for cardiovascular disease, to reduce cardiovascular risk independent of glucose control, GLP-1 receptor antagonists, the group class including semaglutide, of which we'll hear later, SGLT2 inhibitors, the dapagliflozin, empagliflozin group, and we also have to reduce heart failure hospitalization in all patients with type 2 diabetes and HFrEF across the spectrum of ejection fraction, the SGLT2 inhibitor class of DAPA or EMPA. And we also have to reduce cardiovascular and renal failure, kidney failure risk, the SGLT2 inhibitors, and the non-steroidal mineralocorticoid receptor antagonist, finerenone, that I've described before, based on the Fidelio trial program. In the recommendations for glucose lowering of patients with type 2 diabetes and atherosclerotic cardiovascular disease to further reduce cardiovascular risk, the novel concept is special attention is given to the aspect of proven CV benefit or safety of medication. So this is now no longer a glucose-focused response, but it's saying the principal aim of treating these patients is to further reduce cardiovascular disease risk, and that means particular anti-diabetic medication. So it is recommended to prioritize the use of glucose-lowering agents with proven CV benefits by using agents that have established that in major trials, as well as to switch glucose-lowering treatment from agents without proven benefit to agents with proven benefit, with the two most important drug classes being the SGLT2 inhibitors and the GLP-1 receptor agonists. If we look now at the recommended treatments for glucose lowering in patients with type 2 diabetes, we have the historical treatments of metformin, which initially was an initial medication, class 2-1 recommendation, that we still do for low-risk patients. Then if you have higher risk without atherosclerotic cardiovascular disease, you might have metformin and or an SGLT2 or a GLP-1 receptor antagonist with a class 2B recommendation. But as soon as you have very high risk or established atherosclerotic disease, then you need to push with a class 1 recommendation, the SGLT2 inhibitor and or the GLP-1 receptor agonist. Then we had recommendations for heart failure treatments in patients with heart failure with reduced ejection fraction and diabetes, where we have 4 class 1A recommendations. The use of the SGLT2 inhibitors, DAPA, EMPA, and the composite SGLT2 and 1 inhibitor, sotagliflozin, to reduce in all patients with HFrEF and type 2 diabetes. We have a recommendation for the ARNI, sacubitril/valsartan, or an ACE inhibitor in all patients with HFrEF and diabetes to reduce subsequent risk, as well as beta blockers and mineralocorticoid receptor antagonists. So a strong recommendation for effectively heart failure treatments in patients with heart failure and type 2 diabetes with HFrEF. Oops. Then we have recommendations around revascularization in patients, as you see here, in patients with diabetes acute coronary syndrome with no indication for anticoagulation. In the presence of acute coronary syndromes or chronic coronary syndromes, we have the recommendations where you use dual antiplatelet therapy versus low-dose aspirin, and the exception being CABG suggests low-dose aspirin as the primary treatment. And then for PCI, you have dual antiplatelet therapy for the first 6 months, followed by low-dose aspirin. In the acute coronary syndrome, you have 12 months of treatment with dual antiplatelet therapy before conversion to low-dose aspirin. And in patients with PCI, you have 12 months of dual antiplatelet therapy. And then based on bleeding risk, you might use dual antiplatelet therapy for up to 3 years and then convert to low-dose aspirin. Then we had the 2023 ESC guidelines for the management of acute coronary syndrome, and the novel concept of combining STEMI, ST elevated MI, non-STEMI, and unstable angina in a single guideline, and to triage and early management of patients with acute coronary syndrome. This was presented by Maria Rubini on behalf of the task force. It concentrated on the algorithm, the 0 to 1 hour, 0 to 2 hour algorithm, on the use of high sensitivity troponin algorithm, with the recommendations of what to measure and what to take based on those troponin level estimations, with a 3-hour sampling and additional tests to follow. Then in the figure 8, the bottom panel, was what to do in very high risk patients with confirmed non-STEMI based on the ESC algorithms. Highly complicated algorithm that's difficult to summarize, but it's useful to have when you're managing these patients. And it's really stressing the difference between risk levels of very high risk with immediate invasive strategy, high risk having invasive strategy down the bottom, and then non-high risk patients where it leads to that based on the risk assessment. In summary, patient risk dominates, with very high risk going to immediate invasive strategy. High risk, you should consider early intervention, but manage it without patients, no risk, and selective use of invasive strategy later. There was a stress that fibrinolysis is recommended if timely PCI cannot be performed, provided timely access, but you would prefer providing timely access to rescue PCI. Then there are recommendations for cardiac arrest and out-of-hospital cardiac arrest. No major changes there. A primary PCI strategy is recommended in patients with resuscitated cardiac arrest and an ECG with persistent ST elevation. That's a class 1B recommendation, but there's a class 3 recommendation against routine immediate angiography after resuscitated cardiac arrest in hemodynamically stable patients without persistent ST elevation. And then there's a recommendation of temperature control for patients who remain unresponsive. Recommendations for cardiogenic shock. We're stressing now in patients with acute coronary syndrome and refractory cardiogenic shock, short-term mechanical circulatory support may be considered. That's a class 2B recommendation without major trials, but it's recommended against the routine use of intra-aortic balloon pumping in acute coronary syndromes with cardiogenic shock. The intra-aortic balloon pump is not recommended. In summary, antiplatelet therapy and anticoagulants are recommended for all patients with acute coronary syndromes. 12 months of potent P2Y12 inhibitor-based dual antiplatelet therapy remains the default treatment regime, and alternative strategies aimed at reducing bleeding risk can be utilized based on the clinical situation, including DAPT, short-term DAPT, and DAPT de-escalation, with the threshold up to 3 years before converting to low-dose aspirin alone. Then we look at comorbid conditions, chronic kidney disease, class 1C recommendation for the same diagnosis therapeutic strategies, 1B for low isomolar contrast usage, and hydration for the angiography. For older adults, the same diagnosis treatments, frail patients, individualized treatment recommendations and personalized based on patient overall condition, and new recommendations to patients with cancer. An invasive strategy of life expectancy is expected to be 6 months or greater, but conservative if a very poor prognosis. And in diabetes, assess glycemic status in all acute coronary syndrome patients. And a central algorithm to give you the reminder of all these recommendations. So very complex and technical recommendation. Then changing speed slightly, there was a very interesting study on semaglutide, the GLP-1 receptor agonist, in patients with heart failure and preserved ejection fraction and coincident obesity, presented by Mikhail Kosiborov. This is a very interesting study, the first significant size study of this new very effective agent for weight reduction, particularly looking at the heart failure population. So this included patients with heart failure and preserved ejection fractions equal to or above 45%, NYHA functional class 2 to 4, KCCQ less than 90 points, and 6-minute corridor walk test at least 100 meters, plus one confirmatory feature in elevated LV filling pressures, elevated natriuretic peptide levels, and structural echo abnormalities, or a heart failure hospitalization within the 12 months, and an ongoing requirement for diuretics. Patients were randomized to an escalating dose of semaglutide, up to 2.4 milligrams subcutaneously once weekly, compared to matching placebo, and then with 52-week follow-up. You see the key exclusion criteria, including prior or planned bariatric surgery to reduce stomach size. What we saw was a dramatic reduction in weight. You see a minus 13.3% weight reduction over 1 year compared to only minus 2.6 on placebo. Highly significant difference, showing very substantial weight reduction. That also, and I haven't got the details here, but that was associated with improvements on clinical endpoints, large magnitude of benefits, and clinically meaningful in highly statistically significant. There was a lower end-terminal proBNP, despite the fact that reducing obesity might be expected to increase end-terminal proBNP, and there were fewer heart failure events versus placebo. Semaglutide was very well tolerated with fewer side effects, serious adverse events than the placebo group, and together the authors concluded these results indicate semaglutide is a valuable therapeutic option in the management of patients with HFpEF and obesity, and we would love to see a specific outcome trial done in HFpEF with obesity to see if reducing the obesity with these newly very effective agents can improve major outcomes with heart failure. Then changing gear again, there was further evidence about the use of iron replenishment therapy in patients with heart failure with iron deficiency, the HEART-FID study, a very large study. And what this study showed is in about 3,000, just over 3,000 patients, randomized placebo or ferric carboxymaltose intravenous therapy. The treatment's been shown in many chronic heart failure studies with dosing at 6 months and possibly at 12 months, although not all the patients had this second treatment. Visits then every 3 months or dosing every 6 months as needed. The primary endpoint was the hierarchical composite endpoint, the win ratio for all-cause mortality at 12 months, heart failure hospitalization at 12 months, and change in 6-minute corridor walk test distance at 6 months. The top secondary endpoint was the conventional composite endpoint of CV death or heart failure hospitalization. Conventional inclusion criteria, ferritin less than 100 or ferritin 100 to 300 with TSAT less than 20%. They needed a heart failure hospitalization within 12 months or elevated end-terminal proBNP as documented there. Now, it's very important that this was now using the win ratio, and the win ratio is a relatively new endpoint. And so the result was done with an unusually high level of statistical certainty being required to assess a positive trial. The p-value had to be less than the p.01 level rather than the conventional p.05. What we see is the primary hierarchical endpoint based on the Wilcox and Mann-Whitney was p less than p equals 0.019. You might say that's statistically significant, but the pre-specified statistical analysis test said it would only be considered positive if it was less than 0.01. So technically, this was a neutral trial, although the trend was very highly in the right direction. You see that the difference in all-cause mortality was favored for ferric carboxymaltose. The difference in total heart failure hospitalizations, 270 fewer events, was also 332 to 297 in favor of the iron therapy group. And the improvement in 6-minute corridor walk test, although it was better, the difference was very small, with only 4 meters difference, which possibly is not clinically important. So in summary, HeartFit was the largest ever study to assess the long-term safety and efficacy of IV ferric carboxymaltose in heart failure with reduced ejection fraction iron deficiency. It was well powered for the primary and top secondary endpoint. It appeared safe and resulted in a very modest improvement in the composite endpoint, but that was not statistically significant based on the pre-specified statistical significance. However, if you take the totality of all evidence for intravenous ferric carboxymaltose with prior studies and the FIT-HF, there is evidence of overall safety as well as very frequent clinical benefits of the use of IV ferric carboxymaltose in HFrEF with iron deficiency. Then there was presentation of multivessel immediate versus stage revascularization in acute myocardial infarction, the multi-SARS AMI study. And this was led by Dr. Sterley. The study design was shown here, 1-to-1 randomization of immediate PCI during the index procedure of non-culprit lesions, about 418 patients, versus a staged PCI within 19 to 45 days of the non-culprit lesions detected at the angiography. Primary endpoint was all-cause mortality, non-fatal MI, stroke, ischemia-driven revascularization, or hospitalization for heart failure at 1 year. Primary and secondary outcomes effects shown here. You see there is a significant treatment benefit there for the primary endpoint. Treatment effect, 48% protection, confidence intervals going from a 72 to a 28% difference. There, if you look at secondary endpoints, some were significant: non-fatal myocardial infarction, unplanned ischemia-driven revascularization, but also stent thrombosis, acute kidney failure, and major bleeding were events of interest that didn't have significant differences associated with them. In conclusion, the multi-SARS AMI trial demonstrates that in patients with STEMI and multiple vascular disease, multivessel disease, immediate multivessel PCI is non-inferior to staged multivessel PCI based on the 1-year risk of the composite all-cause mortality, suggesting this is a valuable option and may be more effective. Then there was the FRAIL AF study that was looking at the safety of switching from a conventional anticoagulant to a novel oral anticoagulant agent in frail older patients with atrial fibrillation. This was presented from the Department of Primary Care and Nursing Science. What it showed, when 1,330 frail patients with atrial fibrillation were randomized to either continuing with conventional vitamin K antagonists versus being switched to NOACs, modest-sized trials, 660 versus 660, then what we saw was the primary outcome was actually more likely in those converted to NOACs. And that was largely driven by an increase in risk of bleeding. You see there with nearly a 70% increase in bleeding. So in conclusion, FRAIL AF was a unique study. It's the first randomized NOAC trial that exclusively included frail elderly patients, and the recommendation was switching from a vitamin K antagonist to NOAC should not be considered unless there's a clear indication because of the 70% greater risk of bleeding with the NOACs in these frail elderly patients. We also had, in a similar area, the efficacy and safety of dapagliflozin in acute heart failure, presented by Zachary Cox. The DICTATE AHF built on the background of increasing evidence for the use of SGLT2 inhibitors in acute heart failure, screening, randomization, baseline assessments then looked at structural usual care with protocolized diuretic titration in 120 patients with acute heart failure admission, looking at the use of dapagliflozin acutely in the hospital admission less than 24 hours after presentation. What you see is no difference in the overall weight change in these patients, but for the dapagliflozin treated patients, the same weight reduction was achieved with a significantly lower requirement for loop diuretics. They concluded that despite standardized high-dose IV loop diuretics, dapagliflozin had a strong signal to improve the efficiency of the diuretics that was supported by increased natriuretics and diuresis for each 40 milligrams of IV furosemide, a decreased total dose and duration of loop diuretics requirements, and a decreased time to hospital discharge. The totality of the DICTATE AHF data would support the early initiation of dapagliflozin in acute heart failure to safely facilitate decongestion and GDMT optimization, suggesting, rather like we saw with the STRONG-HF study, we should have a much greater sense of urgency and start this effective new treatment very early on with acute heart failure. Then we had the RED CVD trial, Reviving Early Diagnosis of Cardiovascular Disease, a cluster randomized diagnostic trial. By that, we mean that instead of randomizing individual patients, we randomize centers to one strategy versus another on a center-by-center basis. So it was a cluster randomized trial randomizing clinical practices. The main inclusion criteria was participation in a primary care disease management program for COPD or type 2 diabetes. This is a strategy looking at practices who had patients with COPD or type 2 diabetes, giving them advice on how to screen for the presence of cardiovascular disease. And the idea was to see how many patients could be detected at 1 year as having either atrial fibrillation, heart failure, or coronary artery disease. The diagnostic intervention was a symptom questionnaire followed by a structured physical examination, the use of N-terminal proBNP and ECG, and proceeding to step 3 in the case of any abnormalities, which was referral at the GP's discretion to specialist care. What you showed is that using this simple intervention in primary care, you had a dramatic increase in the detection of heart failure, particularly heart failure with preserved ejection fraction, a very significant increase in detection of atrial fibrillation, a significant increase in the detection of new coronary artery disease. So any new cardiovascular diagnosis was seen there more than twice as likely to be detected, suggesting this simple primary care algorithm can improve the detection of important cardiovascular disorders in patients without known cardiovascular disease to high-risk conditions, COPD and type 2 diabetes. You see there that there was a 2 to 3-fold improvement in the detection of coronary disease, AF or atrial fibrillation, whether the crude analysis adjusted and restricted to obstructive coronary artery disease. In conclusion, the diagnostic strategy, a very simple, pragmatic one for primary care, more than doubled the number of new diagnoses of important cardiovascular disorders that require specific intervention. It was easy to use. The tools are all available in primary care and was implemented in existing disease management programs for these 2 other conditions. So I'll stop there, but look forward to discussion and further questions we might get about these important new results presented at the ESC. Thank you very much.
Wonderful discussion, Dr. Coates, and I'm sure the audience which has been hearing have actually truly been benefited from the same. We have quite a few questions that have come to us. So the first question is from Dr. Patel. So Dr. Patel asks, in heart failure with mid-range ejection fraction, as you rightfully said, SGLT2 inhibitors have a class 1 indication, while the ARNI, MRAs, and beta blockers have a class 2B indication. Dr. Patel wants to know if in heart failure with mid-range ejection fraction itself, among these 3, among ARNI, MRA, and beta blocker, is there any chance any one of them might ascend up in the level of evidence? If so, which of them seems relatively promising?
Yeah, it's a tricky question because we need to actually have the trials done to get the really hard evidence. The next best thing we can do are 2 things. Either look at old studies that had a few patients in them, or we look at registries, what's happening in routine practice. And I think the evidence is strongest of those three classes for the ARNI, sacubitril/valsartan, because we had the composite of Paradigm and Paragon. It was very close, Paragon, to being statistically significant and was much stronger in that mildly reduced range. And if you do the pooled analysis, it was clearly a beneficial effect over the 41 to 49. So it's only a technicality that there was no specific trial. For the beta blockers, MRAs, the evidence is smaller subgroups from other studies and much older ones. So I think that the ARNI is probably the one most likely to get elevated in recommendation as further information comes in.
Thank you, Dr. Kurtz. The next question actually is on similar lines. A question from Dr. Avinash, and you've partly answered the question, sir. So Dr. Avinash asks, though ARNI missed to meet its primary endpoint in its FF trial, the Paragon HF trial, a pre-specified subgroup analysis showed sacubitril/valsartan to retain its benefits even in patients with an ejection fraction of less than 57. So not the entire FF spectrum, but just less than 57. So the ACC/AHA 2022 guidelines also gave ARNI a 2B recommendation for sacubitril/valsartan in HFpEF in their 2022 guidelines. However, the ESC guidelines have not considered the same. Your views on the same, sir?
Yes, it depends whether you're a purist or a pragmatist. The ESC guidelines have very rigid rules about requiring one or more clinical trials specifically designed to reach its pre-specified analysis, and they don't take subgroup analysis as having so strong. In the US, even the FDA has approved the use of sacubitril/valsartan for heart failure, irrespective of ejection fraction, but noting the evidence is stronger at lower levels. This is also compounded by the fact that the ejection fraction range in which sacubitril/valsartan seems to be superior to an ACE inhibitor might differ depending on gender, with women benefiting to much higher levels of ejection fraction. So although the overall trial, when pre-specified cut point of 57% clearly showed nominal statistical significance in the group under 57%, so it was 45 and above, that varied by gender. My personal belief is that sacubitril/valsartan is beneficial across all the ejection fractions that are not absolutely strictly normal, and you can have a differing opinion on what a normal ejection fraction is. But a normal ejection fraction is probably higher in women. So I personally would treat men up to ejection fractions of 50%, but women up to higher levels, up to about 60%. But we don't have a specific clinical trial to be absolutely certain about that. But the trend is that we are using sacubitril/valsartan in the heart failure with mildly reduced ejection fraction range, as the questioner rightly suggested.
Thank you, Doctor. The next question is by Dr. Anand. Dr. Anand asks, low-dose aspirin from the perspective of a primary prevention strategy, whom and when? Also, whom should be benefited and when should it be prescribed, and whom possibly to avoid it? Your take on this.
Yeah, look, very tricky questions, and it's not the field that I sort of very actively in practice on. But, we have realized that although aspirin has a key role in the secondary prevention for patients with established cardiovascular disorders, atherosclerotic, stroke, myocardial infarction, primary prevention requires very large trials with long-term follow-up. And although we do see fewer cardiovascular events, there's always an increased risk of bleeding, which when you're treating very large numbers of subjects is a counterbalance. And my reading of the literature is the evidence for primary prevention with low-dose aspirin is relatively weak and not recommended on the basis that the number of clinical events you prevent is counterbalanced by a small but clinically possibly important increased risk of bleeding. So in primary prevention, people are moving away from the use of low-dose aspirin routinely. It's completely different when a person's had an event, a stroke or myocardial infarction. At that stage, the positive benefits of aspirin overwhelm those of the bleeding risk. But primary prevention, I think we're backing away from.
Thank you, sir. The next question is from Dr. Priya. So, Dr. Priya asks, Hafner et al. In his landmark study in 1998 proved that diabetes is a CHD risk equivalent. The recent guidelines recommend switching to glucose lowering therapies with proven CV benefits, as you rightfully showed in your slides, and maybe switching over to drugs with proven CV benefits first, followed by CV safe therapies. So, the question that Dr. Priya has is, though this would be ideal, utopian from the best possible perspective care that can be given to a patient, but from a population perspective, what are the anticipated challenges that a clinician can expect, especially when shifting a well-controlled patient from one class to another? Your take on this.
Look, very important questions. I mean, it gets down to the fundamental principle of why we are detecting and treating type 2 diabetes. We know there are lots of complications with type 2 diabetes, and they include atherosclerotic cardiovascular disease, heart failure, but also many other long-term consequences, such as retinal disease, peripheral vascular disease, renal disease. And therefore, we're protecting a patient lifelong with an incurable condition. Now, the question is, what is the individual risk for a patient? And in a young person relatively young person without any manifest atherosclerotic disease, then all we know is that better glucose control gives better long-term outcomes. But if as soon as you get more advanced features or you start getting high risk for atherosclerotic cardiovascular disease, then the large vessel atherosclerosis events begin to dominate the picture. And at that stage, there really is a compelling indication for using certain agents. Now, the reason I say that is that if we maintain the glucose lowering central parameter for the treatment of type 2 diabetes, then we might be led into using drugs that reduce glucose very well, but where we don't know the benefits. And some of those drugs over the past have actually been shown to increase certain atherosclerotic events, particularly myocardial infarction and very particularly heart failure. And certain anti-diabetic drugs, although they're very effective to reduce glucose, could increase the risk of heart failure. And I think of the thiazolidine diones or glitazones as one of those classes. So then the regulators, particularly the FDA, dictated that all new anti-diabetic agents should evaluate cardiovascular safety outcome to check that they're not causing adverse cardiovascular events. And that requirement to detect no increased risk of worsening atherosclerosis or atherosclerotic events led to the finding that certain agents actually were not just safe, they're actually substantially effective. And the most powerful of those were the SGLT2 inhibitors, where trials going back, the EMPERIC outcome trial, DECLARE-TIMI, and the CANVAS program, all showed significant reductions in cardiovascular disease, particularly heart failure hospitalization. So we suddenly had a compelling indication that one drug class had benefits that the other drug classes had not yet been shown to have. Then we had a second drug class, the GLP-1 receptor agonists, that also showed they could prevent major atherosclerotic cardiovascular disease. So suddenly we now have an option of multiple hypoglycemic agents, all of which reduce blood glucose, but some of them have an added benefit of preventing atherosclerotic disease, in particular heart failure hospitalization. And so we begin to shift to saying, look, if you have no other reason to have a choice for one agent, choose the agents with the most profound benefit. And if the patient's very high risk for atherosclerotic disease or has established atherosclerotic disease, or is at very high risk of heart failure, then you really need to use these agents first. And that's now gone over in the guidelines to saying you should even evaluate the patients you have with type 2 diabetes and say, maybe I should start shifting them towards these agents But that's a clinically difficult judgment. If you have a patient who's having no problems, no established atherosclerotic disease, no history of heart failure, then you might say you put at risk by destabilizing. And I think they'd be the lower priority patients. But any new patients or patients who are at high risk, then I think the evidence is in favor of making the change. So I think we need clinical judgment on how widely you extend that recommended change in treatment.
Wonderful, sir. Wonderful. The next question we have is from Dr. Sushant, who first thanks you. He says, a wonderful point discussed by you, sir, thinking secondary prevention as soon as the diagnosis of an ACS is established. An important point you also showed and mentioned was smoking cessation. So Dr. Sushant writes that in India, clinicians commonly prefer and use nicotine replacement therapy, which actually might be deleterious to cardiac patients. So should we consider varenicline in such patient populations, or are there any other anti-smoking cessation therapies that you consider in Australia?
Yes. Look, it's a difficult thing. I think that nicotine replacement is, can actually cut down cigarette use, but whether it's improving outcomes, we don't know. And as the questioner said, I think there are concerns about that. We haven't got really strong clinical trials of other approaches. But in certain patients in high risk, if you have experience with them and you find them effective, then I think they're reasonable choices. We don't have those other agents approved for routine use in Australia, so I'm not as familiar with the use of those for smoking cessation.
Sure, sir. The next question by Dr. Rajesh, he asks, in India, PCSK9 inhibitors are costly. They're expensive. So in patients with CV disease or at high risk, after initiating high-intensity statins and then going to ezetimibe, can we consider bempedoic acid as a third-line agent, especially after the CLEAR Outcomes trial? Your take on the same, sir?
Yeah, I think so. I mean, the trial was supportive of bempedoic acid. It just wasn't as powerful as perhaps we would have wanted to see. But if the agents with stronger clinical trial evidence are not feasible due to cost or availability issues, then certainly I would consider that is a good alternative. So it gets this concept of what's really proven at the highest level, and then practical guidance when that's not possible. What could you do as the next best thing? And I think in that regard, if the cost of the PCSK9 inhibitors is prohibitive, it's just simply not available, then I think bempedoic acid is a very good alternative.
Thank you, sir. The last three questions. So we have Dr. Paresh, once again, who thanks you. He writes, many thanks for discussing, sir, on the STRONG-HF trial and uptitration of guideline-directed medical therapy for heart failure within 6 weeks. He just has a small practical challenge. He says, sir, however, a small challenge in my clinical practice tends to be an increased risk of hyperkalemia, especially when both MRA and ARNI are started at the same time. Any tips and any clinical tips for utilizing them in these patients?
Yeah. I mean, I think in some regard, obviously hyperkalemia is an unwanted effect. It's associated with increased mortality. But probably the worst aspect about hyperkalemia is it leads doctors to stop otherwise life-saving therapy, and they rarely restart them. So analysis of the heart failure long-term registry showed that the risk of patients with heart failure getting hyperkalemia increased the risk of mortality. But if you then took into account whether the MRAs in particular were stopped, you found that all the excess risk statistically was accounted for by the fact they stopped an MRA. And in patients with an episode of hyperkalemia who were maintained on the MRA, they did very well. So there are other strategies. You can have very careful observation and very careful management of the patients. You can use potassium binders, Patirum or SZC, to aid in that. And we know that can be effective. But so my personal belief is that the beneficial effects of maintaining high-dose RASI and in particular MRAs are so great that I think we mustn't compensate. We should tolerate slight elevations of potassium. We should do everything possible to maintain the patients on RASI. The STRONG-HF trial showed a significant reduction in cardiovascular mortality and heart failure hospitalization, but it was at the cost of more cases of hyperkalemia and more of worsening renal function. But that didn't matter in the overall wash-up. So I think the overall strategy is that we probably have been too cautious and too willing to stop RASI uptitration, MRA initiation, be concerned of hyperkalemia. And particularly now that there are potassium binders, we should be a bit more aggressive and keeping hyperkalemia risk in proportion.
So Dr. Iyer asks, he writes, prasugrel has a high risk of major bleeding compared to ticagrelor and clopidogrel. Also, usage of prasugrel becomes a challenge without knowing the coronary anatomy and is contraindicated with patients with stroke or a transient ischemic attack and in elderly patients greater than 75. Also, in those with a body weight less than 60. Hence, from the Indian perspective, he's asking, sir, should we consider and continue with ticagrelor, which is possibly what he uses as a strategy, rather than prasugrel? Or what are the challenges when looking at P2Y12 inhibitors separately? He also makes a mention that in patients with a high bleeding risk and a low ischemic risk, he still tends to prefer clopidogrel among the three agents. Your take on this?
Yeah, look, honestly, I agree with the questioner. I think that, particularly the weight issue is important. And the Indian population is a different population to those of the Caucasian populations in such trials. So I think in an Indian setting, I can easily see that you may well prefer ticagrelor to going over to prasugrel. And I'd be very supportive of that approach.
Thank you, sir. The second last question. Actually, first, Dr. Prathamesh, thanks you for the update on the multi-stars trial and the importance of the immediate multi-vessel PCI. So it's just a thanks, not a question. He just wants to thank you for the same. The last question is by Dr. Parish, the last question for the day. He says, sir, you have wonderfully put forth perspectives for understanding CV risk and renal risk in a diabetic patient, and the fact that guidelines have embraced the perspective of CV risk reduction and kidney risk reduction. Is there also a need, and maybe will we see future guidelines where NAFLD and NASH is considered, or maybe COPD is also considered as another factor while seeing CV disease and diabetes together? Your take on this, sir.
Yeah, that's a very important. I often say in my lectures that we specialize in different branches of medicine, and I use the term giblotologist for someone who's very interested in one organ to the exclusion of all the other organs. But what happens in the body is all our organs interact with each other on a regular basis. So heart, kidney, liver, brain, they're all constantly interacting, and they interact more with each other than we interact with other specialities. And we're all looking after the same patient. And so a person with type 2 diabetes or established cardiovascular disorders or established chronic kidney disease almost certainly have worsened the other aspects of disease. So we're beginning to learn a lot more about what's now called cardiorenal metabolic, and particularly the SGLT2 inhibitors, GLP-1 receptor antagonists, and now with the non-steroidal MRAs, we're seeing beneficial effects in diabetes on both the kidney and the heart, and the prevention of heart failure, which is really positive. But as the questioner rightly points out, conditions that apparently look quite clinically separate, like NASH, non-alcoholic steatotic hepatitis, are probably also very aligned to metabolic syndrome and have a high risk of cardiovascular disorders and can respond to similar agents. And COPD, although it's, the lung and not the heart, actually has a very high rate of cardiovascular disorders. the heart is not innocent in COPD, common risk factors. So I am absolutely certain, I agree with the principle behind the thing, that we will learn a lot more about the interaction of these disorders. And we need to design trials specifically looking at comorbidities. And I believe that some of our cardiovascular drugs will be beneficial in both NASH and COPD, even agents like beta blockers, which you might say should be contraindicated in COPD, are probably beneficial. So these disorders all tend to go together, and they have similar abnormalities in multiple organ systems. We're only at the beginning of a long journey as to how best to use the treatments to protect all our patients and patients with multiple organ dysfunction.
Thank you so much, Dr. Coates. We are towards the end of our session. It's been an astute evening, and we've had such a wonderful and interactive audience. In fact, we see 2 comments actually writing to us, we want a version 2.0 of this talk. So,
Right.
so a very interactive audience, which has actually learned a lot from this particular talk. We take this August opportunity to thank you for the same, for spending your valuable time to come here and enlighten us on what was new with the ESC in 2023. Dear audience, we also thank each and every one of you for taking your valuable time to actually join here, attend the session, and we are very sure that all that has been discussed ultimately translates to improved patient care and improved patient outcomes in individual clinical practice. Last but not the least, we also thank our dear technology partners, Club Class, for aiding in the very smooth streaming of this webinar. Thank you, one and all. Good night. Thank you, Professor Coates. An honor.
Thank you. Have a great afternoon, everyone. Or a great evening.
Have a great day, sir.
Right. Bye.